a few things about the world and the profession of psychiatry. Currently, there are huge issues with shortages on rotas across the country, psychiatry being first and foremost one of the major specialties which has difficulties in terms of filling certain rotas. And one of the major concerns in terms of our staffing issues is that we have a lack of medical specialty training spots. I think that's something which we are all looking to increase, and we simply don't have enough. There's not enough funding at the moment to fund Health Education England to provide those spots. What will you be doing to advocate for more training spots in psychiatry across the country?
So funny enough, actually, I've already done a bit of this anyway. I was involved with the Mental Health Act review, and I was giving evidence to Parliament, and I was saying to the MPs, we do need more staff. We really do need more staff, actually. We need more training. We need more staff. There's no doubt at all. We are chronically understaffed. We are chronically under-resourced in a number of ways, in terms of finances, in terms of our facilities, and in terms of our staff. I actually even went on television and said this actually as well. And the reality is that for some reason, for many years, there hasn't been an increase in the number of training places, and there certainly hasn't been an increase in the number of doctors that are needed yet. And we find ourselves with this real shortage. And what I do remember a few years ago, there was a recognition that they needed more medics, so they actually, created some new medical schools. So someone had done the modelling for that, but they still haven't got it right. We still need more. We still need more medical school places. We still need more training places. We need more doctors. And so, the Royal College of Psychiatrists has already done quite a lot of work on this. It's been estimated we probably need about an extra, it's probably in the region of about 700 or 800 psychiatrists to meet the need, and that's not the demand. We are talking about the need. And you have to grow those people. If you haven't got the medical students coming through, because not every medical student wants to be a psychiatrist, if you haven't got the medical students coming through, then you're not going to grow the doctors, and you're not going to grow the psychiatrists. What happens instead is that we're reliant on people choosing to come to the country from overseas. And in fact, we're really heavily reliant on international medical graduates. Thank God for them, because without them, we wouldn't have any kind of health service. What we don't do very well, however, is, in my opinion, I don't think we look after those international medical graduates very well at all. And that's something that I'm already working on and will continue to work on. But as for junior doctors, no doubt at all, we need more. We need more doctors, we need more training places, and we also need to make sure that the specialities are thriving so that there are people to train the juniors.
Certainly. That is a core component, that we have to have enough undercurrent and we have to have enough growth at the junior stages to sustain our workforce in terms of our senior doctors, in terms of our consultants, because if we don't have the throughput for juniors, we will simply won't be graduating enough consultants to lead and take care of them either. Now, in terms of advocating for psychiatry funding at the very highest levels, in terms of the profession, what ideas do you have in terms of how we can best advocate for extra funding in terms of psychiatry, and what we should be utilising that funding for as well?
Good question. So, there's not much money around at the moment, but one of the bits of good news, I mean, we are 55% underfunded, and that's been chronically underfunded for years. A few years ago, however, I was involved in some work around this, developing community mental health transformation, and we developed this framework with NHS England, and of course, there are other NHS establishments across the 4 nations, but we developed this with NHS England, and the evidence that we used to develop the community mental health transformation, was then used by Tim Kendall, Claire Murdoch, who are the national directors of mental health and national clinical director of mental health, to argue for more funds for mental health. So the good news is, as part of the long-term plan, the work that we did was used to petition NHSE, and we managed to get £2.3 billion of ring-fence funding for mental health. And that's money that's now this year just being seeded down into the various mental health trusts, and should be being used to improve and enhance community mental health services in a way that, and having written this thing, it's in a way that should allow you, and I hope that people look at the long guide, and the long guide says, right, what people need is continuity of care, because a therapeutic relationship helps to provide a longitudinal view of the person's needs. And when you get to know that person really well, then you understand when they are becoming unwell, you're able to help support them to get better when they become unwell and help them to stay well. You understand about the whole of their lives, their biology, their psychology, and their social environment, and how that impacts their health. And it forces, if you're doing it properly, it says you must provide this really good upfront biopsychosocial assessment with formulation. You can provide a treatment plan that you as the senior psychiatrist can oversee. The treatment can be done by other members of the team, and it's overseen. And then there's a long-term input, so you can review whether or not it's worked, and you can basically keep looking after that person long term. That's very rewarding, much more rewarding actually. And it also reduces paperwork, it reduces bureaucracy. And having worked in a system like that before, it was actually I think it was more useful. It was definitely I think people had better clinical outcomes. There were fewer relapses. At that time there were a few people detained in hospital, and it was, I think, it was definitely more rewarding to work with people in that way. So we don't have enough money yet to cover all our services, but we do have this ring fence funding. Big thing for me at the moment is that people spend it wisely, and there's guidance there to help you, I know, because I've written it.